Recording.
Awesome. And for folks who haven't been here today on this before, everything will be posted on the Blueprint for Health website in the next week or two. So I'm really excited about today's training. It's part one of a two-part series around pediatric mental health. Today's is on medical home and mental health partnerships. And we have three wonderful speakers with us today. Haley McGowan, who's the Children's Medical Director of the Vermont Department of Health and also has a very important role at the University of Vermont as well as a child and adolescent psychiatrist. Laurel Omland is the Child, Adolescent, and Family Unit Director, also at the Vermont Department of Health. And we are joined also today by Jessica Coleman, who's the Senior Clinical Manager of Intensive Services for Howard Center and NFI Vermont. Haley, can you just go quickly to the next slide? Just a reminder, this is, we forgot to change this, but this is the series that that many of you have all been participating in. And today is around mental health medical partnerships, and next month is around school and medical home partnerships. Next slide. And with that, I think I'm going to pass it off to Haley. So thank you all for being here today.
Great. Thanks, everyone, for joining today. We're happy to be here. I think we're scheduled technically for longer than an hour, but we are probably going to try and keep it on the shorter side. Also knowing that a lot of us are dealing with snow days and children at home. That seems to be statewide. So so you can see our objectives here. Like Elisa said, I'm the Children's Medical Director at DMH, but my other hat is in primarily in the emergency department at the UVM Medical Center. And so that's sort of been my lens on the system of care. And then Laurel has sort of that high level, state level lens on the system of care. So she'll be talking more about that and the role of greater DMH in terms of these medical home mental health partnerships. And then Jess Coleman has a lot of on the ground experience and will be really kind of bringing some firsthand knowledge of how this actually works to the conversation. So we're hoping this can be pretty conversational, so feel free to interrupt as we go. There will be time for questions at the end, but if questions come up, feel free to put that in the chat. We'll try and keep an eye on that or raise your hand. And, knowing that this is the lunch hour, we're not doing breakout rooms or anything like that, but we have embedded a couple polls that we hope you can participate with as we go, just to kind of get a sense, of where everyone is at as we move the discussion forward. So maybe like I think there's 4 poll questions total that you should just be able to click on the screen. We're going to try and do that. And then a couple just type in the chat what your thoughts are, sort of thing. We would really appreciate if any participation there. So these are our objectives for today. We're going to sort of do an overview of the child, youth, and family system of care for mental health. Hope to increase some of your knowledge of the levels of mental health care for children, youth, and families. I'm expecting that there's a broad range. Some people who are very familiar in doing this for a long time, and others who maybe are newer to understanding, the Vermont system, and talk a little bit about the barriers and facilitators to medical home and mental health partnerships, and kind of what helps, what doesn't, and maybe even do some troubleshooting together. We're going to try and frame this within a completely made up case. It's not a real child, but just something to sort of help anchor our conversation as we move through. A little bit of jargon busting. Let's see. So, sorry, didn't mean to do that. These, I'm not going to go through all of these, but these will be in the slides just for your reference, because there are a lot of acronyms in state government, in mental health in general. So this you can always refer back to, and we tried to make sure that we had jargon busting available for all the acronyms we use within our slides, at least. And then Laurel's going to talk a little bit about, well, I guess first I could just talk about our unit. So the Vermont Department of Mental Health. Oh, wait, Laurel, you're going to do this one. You go ahead.
Yep, no worries. Yep. Hi, everyone. Laurel Omland. Great to have you all here. We just wanted to highlight, we have a smallish central office focused on children's with myself and Haley. And then we have a care management lead, who's our operations chief. We have 3 care managers who are really our points of connection with our community mental health system and trying to help problem solve as situations and children and youth are needing to access different levels of care under Medicaid, that our care manager team can help with that. And then we have someone focused on school mental health programs. And then whenever we have some additional federal funded projects, we have coordinators connected to that. So just wanted to highlight a little bit of like, who are we at DMH? So next slide. So these are, the next couple slides are ones that we use across our department just to convey to folks who aren't as familiar with the system, like, how do we think about this? And so we think about our system as to try to have a coordinated mental health continuum of care. We want someone to prevent, someone to call, someone to respond, and somewhere to go for folks. So these are examples of what is in place around activities to try to do some prevention or early, upstream work. We have a newish responsible gaming program. We have a suicide prevention initiative that's definitely in concert with our colleagues over at Department of Health with Elisa and others in that team. And then we have a lot of focus around trauma prevention and resilience development. On the someone to call, we want to make sure that people have places to call when they need some support. So really wanting to promote and hope that you all also are helping to promote the new national 988 Suicide and Crisis Prevention Lifeline. We have some resources for you all online or to even pick up at various places where we might have some tables to be able to post information about that at your sites and make sure that the folks that you are connected with are aware that that is an option to call and get connected to. It's either call, text, or even chat. So we can get a link for more information about that. And then someone to respond. This is really where we are trying to build up that enhanced mobile crisis response team across the state, where it's a 2-person team, including a credentialed peer support person, to really be able to get out to where someone is to be able to provide in-person support in moments of crisis, as well as our more traditional emergency services supports through our designated special service agencies where there might be a need for screening for consideration of whether someone needs inpatient care or not. So those are kind of the 2 big aspects of someone to respond. And this is really like thinking about more of a crisis type system, somewhere to go. We also don't only want to have inpatient psychiatric care as a place to go. We want to try to build up care at lower levels. And that includes things like alternatives to emergency departments, urgent care, mental health urgent care type settings, hospital diversion and crisis stabilization programs, which we have for children. And then for some longer term care, there might be some residential or other group home type settings in the community. But I think what we really want to get at, actually, let's go to the next slide, is what does this look like kind of across our system? So this is a way of visually trying to represent the levels of care that we have available and wanting to also just highlight, the foundational aspect of this is our community-based supports and providers. And that's where we want to ensure that there is access to care and that needs are being identified and addressed as early as we can and in home and community settings, especially for children and youth. But if needs escalate or aren't able to be supported at that level, that there are other levels of care that can be responsive to that. And so this visual actually reflects the full continuum across the ages. So just to orient you a little to the key, it might be a little small. The orange are services and supports that are available regardless of age. The blue is for adults needs in our system, and then the green is for child and youth supports. So If we can actually back up one slide, oh, no, it was the next. Sorry, I was missing the order that we had. We have our mental health designated agency system, which we'll get to in a minute, that provides a bulk of our Medicaid-funded supports to children, youth, and families in the community, and that can happen in the office, but also in homes and in community settings, such as in schools, through school mental health partnerships, as well as some who might be connected with primary care offices, for example. And that can really cross the spectrum of early child and family mental health to school age supports for school age youth, and then transition age youth, and trying to make sure that as youth transition into adulthood, that they still have a system of care to help them remain connected to healthcare coverage, to healthcare providers, and to be able to access mental health supports as needed. So we really, in the children's division at DMH, really try to think about that full continuum from the perinatal period and early childhood development through school age and into transition age youth. And then how do we make sure that older youth or young adults can get connected to the adult system as needed from there. This we do try to keep as up to date as we can because things continue to change. I'm sure you've heard, about the closure of inpatient unit for adults at CVMC, and so some of these numbers, this should be current as of January, acknowledging that piece. For children. We do have, as I mentioned, at the crisis line, we have Children's Crisis Stabilization Program run through the Howard Center in Chittenden County. We have 2 youth hospital diversion programs that are run by NFI. One is in the Chittenden County area, one is down in Brattleboro. And then we have mental health urgent care programs for youth at some different regions around the state, which we'll get into. We do have residential programs, both that we access through Medicaid in Vermont, as well as out of state if the Vermont programs aren't able to meet the clinical needs. And then we have one in-state inpatient facility for children and youth at the Brattleboro Retreat. But there's also an option for youth who are voluntary for inpatient to be able to go across the lake over to CVPH, Central Vermont. Not Central Vermont, sorry, Champlain Valley Physicians Hospital. All right, let's go to the next slide. So this is to represent our designated agencies. I'm sure you're familiar with these if you've been working with children and youth for some time, but Department of Mental Health designates agencies to provide public mental health services in each region of the state. And this shows that some of those designated agencies, or DAs, as we might call them, might cover more than one county. So in the Northeast Kingdom Human Services covers Orleans, Caledonia, and Essex County. Down in the South, Healthcare and Rehabilitation Services of Southern Vermont covers both Windham and Windsor County. And then our Northwestern Counseling and Support Services covers both Franklin and Grand Isle counties. And then the others are really county-based. And then we have one special services agency, which is Northeast Family Institute, or NFI, who can provide both community-based as well as they run some residential and, as I mentioned already, hospital diversion programs around the state to meet the more intensive needs of youth. All right, let's go to the next slide. So I guess what I would say with that one actually is to make sure that you are familiar with your local designated agency. Think about, do you have point people there that you can call if you have questions about how do you access care? We'll get into a little bit of that. And we do have Jess Coleman on, who's connected with some of those agencies as well. To you, Haley.
All right, so I'm going to try this whole thing. So let's see. Hopefully this will pop up for everyone. Responses are anonymous, and then we'll just share the congregated data. It's 2 questions, and then I think we will have to go to the chat to see what the results are. Is everyone able to see that? Is that popping up for people? Okay, great. I'll give you a minute to do these 2. And the first question is really, just about whether you've yes or no experienced challenges with connecting to services. And then we were interested to hear, what barriers you most often encounter. If there are others you'd want to put in the chat, feel free. But we together brainstormed this list just to see what rises. All right, so I'm gonna see. I'm gonna close the poll. And let's see if we can see the responses. Can people see the responses in the chat? Great. So it looks like we have 87% of people have experienced challenges connecting pediatric patients with mental health services. Not surprised. I'm happy to hear that 13% haven't, to be honest. That's wonderful. And then for the second, let's see. So rank the following challenges with accessing mental health services. Looks like the number one was scheduling. Scheduling, followed by family and patient follow through. Third being provider openings and availability. Then transportation. Last, unsure where to refer. So that's great that you feel like you have a sense of where to start. I'm happy to hear that. And insurance barriers being the lowest. Okay. Thank you very much to the 30 who responded. And now we'll keep moving. Okay, Laurel.
Okay, for others, I had to click the arrow button to see the next part of the poll. And if you weren't able to do it because of some block or whatever on your computer, feel free to put thoughts in the chat. We welcome that also. This again is something that we've used in testimony and just broader conversations. Wanted to have you have this to be able to access, but one thing I did want to highlight, and again, I'm sure many of you are familiar with this, but for children and youth who are enrolled in Medicaid, they have rights under the early periodic screening, diagnosis, and treatment Medicaid requirements to be able to be screened. And that is obviously something that it happens under Bright Futures at pediatric offices, but also as it relates to mental health needs. And so we want to make sure that youth are being screened as needs are picked up, that they are able to be diagnosed and treated at the right level, at the right time, and at the right place. So wanted to note that, but let's go to the next. Oh yeah, this was just it. So you can see it a little bit better. Keep going. Okay. Sorry, I do want to not spend too much time on some of these basic things. You're welcome to read it, but also glad to answer questions because we want to make time available for people if you do have additional questions.
Okay, so we are gonna, like I said, try and anchor this in a made-up case. So just, to start the conversation. So we're today going to consider a 10-year-old girl who was seen in a PCP office where you may work for more of a well child visit. This child, we're going to say, moved to Vermont last year, so relatively new to our system of care, doesn't have a long history here or, experience accessing various levels of service, a history of early trauma, and adopted by the current family that she lives with in Vermont. She is at this point struggling with behavioral regulation and self-esteem. They're having some challenges at home, with big feelings, big behaviors that are sometimes now spreading to the school setting. And then at this point, there's no known role of DCF. Just always important to inquire about that because sometimes they have more history than we're aware. So to start the conversation, we're really just going to focus on levels of care. We always want to start at the least restrictive level of care, whatever allows someone to stay in their community. Outpatient supports in general, you guys are all very aware of this, are, individual therapy, group therapy, family therapy, psychiatry. There's various ways to access psychiatry in the state of Vermont, and I'm not dismissing that can be challenging. The Vermont Center for Children, Youth, and Families is at UVM Medical Center, and the waitlist is significantly better than it used to be, requires a referral through the primary care office. That's something that you all might be doing and following over time. But it's in the past, it had been over a year and is now, I believe, down to a couple months. So that's encouraging. And then you can access psychiatry through the designated agencies sometimes too, but usually you have to already be engaged in their lower levels of care, something like, like therapy or some of their community-based services in order to get to that point of getting a psychiatry appointment, just because they're, they have to sort of limit the volume where they can because they have limited psychiatric staff. And then other outpatient supports might be home and community-based supports via the designated agencies. And that kind of comes at various levels. Sometimes that just means, going to the agency to participate in, groups, therapy, that sort of thing. It might also mean home-based services where someone is like a skills worker is coming and doing something with a kiddo, once a week, or coming into the home and trying to do some family work on a regular basis. So there is a kind of a broad range, and it does vary across DAs. And just for Laurel and Jess, I'm not able to watch the chat at the same time. So if questions are popping up, just, pipe in and let me know. For at the next level, sort of the beyond just basic outpatient supports, we have intensive outpatient programs, and that is pretty limited at this point in Vermont. I'd say the most the one that people are probably most aware of, and really the only one that we have access to, is NFI Crossroads program, which is a DBT-based program, intensive outpatient program, or IOP, as we say. There are two of them. There's an adolescent one that has been around for quite some time, and then there's a much newer transition age one, for that 18 to, like, I think they say 25, something like that range. The NFI Crossroads is intensive outpatient. Essentially means you're going several hours a day, usually several days a week, for a finite period of time. Something like it could be 6 weeks, could be 10 weeks. I think it's usually on the lower end of that, but I think it does vary somewhat case to case. They do family work as well. That's part of the treatment. It's self-referral, so families have to, to express real interest, they have to reach out and do the referral themselves, but can often, be supported, excuse me, in doing that, by care coordinators, by psychiatrists, by whomever, by the emergency department. Sometimes we help with that. So that is, there is often a wait list for these programs, but it is a really great service. And then last I have on this list for outpatient alternatives to emergency departments, which has really been a big focus from the state level over the past few years, given the challenge with kids boarding in emergency departments, just like the emergency department feeling like a kind of it was becoming a default in many cases. And so there was a huge push to, figure out how do we keep people, in their communities at the more appropriate levels of care and provide the level of support they need without having to go to the emergency department. And, for a million reasons why the emergency department might not be the right fit. Sometimes it's needed, right? If there's a risk, I wouldn't hesitate from sending kids to the emergency department or families, if you're worried about safety or that sort of thing. But sometimes that's not really what's needed, and we just haven't often had an option below that. So there's been a real push for these alternative to emergency department programs or urgent care, psychiatric urgent cares, which we'll get into a little bit more in a few minutes. Laurel.
So for those, I think Haley was trying to highlight, like, what are some of the various outpatient options in general? There are other things, right? Every region has different supports and services. So we certainly didn't want to try to name all of those, and our hope is that you are connected in with what is available in your community. But we did want to highlight the things that we have some direct oversight with from Department of Mental Health. And again, that's the designated agencies. So they can offer the various therapies, individual, group, and family, med management. As Haley highlighted, they can also offer for kids who have the identified need, supportive counseling and skills development, some in-home supports, and that can look different depending on the age of the child and youth. The Early Child and Family Mental Health has some evidence-based practice training around how to provide some pretty intensive parenting skill development. And so that would really be that dyad that they're working with. And then for older youth, perhaps it's more working with the youth themselves and then checking in with the parent or guardian as needed. There are respite services available. I will say that some of that got impacted during COVID, and so agencies are trying to build that back up and identifying providers to offer respite with families, to give families just a break. so that they can focus on another sibling or just be able to kind of refresh and regenerate because parenting kids with some of these challenges, it can be exhausting. And so wanting to acknowledge that if they had that break, it might help them be able to maintain and continue to support and that youth remain in the home rather than going to a more intensive out-of-home type setting. There is service planning coordination and case management available. I will say, again, kind of our oversight, it relates specifically to Medicaid. There have been some pilot programs where some designated agencies have tried to partner with commercial insurance carriers to cover things beyond just therapies, but that is not necessarily available across the board. So that I need to acknowledge that aspect of it. The good thing in Vermont is we have great coverage for children as far as insurance coverage. It can vary depending on what that coverage actually is. The last thing on the list for designated agencies is JOBS, which is an acronym of a program, stands for Jump on Board for Success. And that's really for that transition age youth and young adult population to help them have supports to address their mental health needs so that they can either complete a high school degree or degree equivalent or engage in career development, job engagement, et cetera. So there's some programs specific to that. I mentioned the early child and family mental health, which really works with that perinatal through up to age 6 population of families and providing some really targeted supports around parenting and parent management, as well as direct intervention with children. And then our school-based mental health program, all of our designated agencies have some local agreements with with many of the local districts across Vermont to provide some form of school-based mental health. That can look like a school-based clinician, so a master's level person embedded within a school providing clinical supports. It could be a behavioral intervention program that provides more intensive one-on-one supports for students, typically students who are on an individualized education plan or special education. And then a few agencies also provide therapeutic schools in an independent school that's run by the designated agency. So something like the Baird School or the Jean Garvin School in Chittenden County, the choice programs in Washington County. For those who are in those locales, you might be familiar with it. Those independent schools can actually receive students from other regions as well. There's a lot more around school mental health that we could talk about. We have a federal grant really trying to look at how we can infuse a multi-tiered system of supports in schools with mental health expertise to really address the social, emotional, behavioral needs of students across those levels of support. But I'll keep it to that brief summary. Let's go to the next slide.
For this, I was just going to add, it should actually say Chittenden and Franklin counties. For some reason, the edit didn't hold in this version, but yep, go ahead. For Spectrum.
Yep. So again, some things that aren't necessarily under our purview, but certainly are important parts of our system of care. There are parent-child centers in every region that can provide additional supports for people in parenting roles. Higher Ability provides supports for people with disability to help them develop skills for employment. Spectrum Youth and Family Services, as Haley said, is in both the Grand Isle and Chittenden County region to provide some additional supports for youth. Outright Vermont is statewide support for youth who are LGBTQ and provide both training for people to understand how best to recognize and support the needs of those youth, but also helps grow gender sexuality alliances in schools and provide other supports for youth, including summer programming. Post-adoption supports can be really important for those families who are adoptive, formed through adoption, to be able to support them to understand and access different parts of the system to meet their family's needs. And then, of course, I'm sure, and you've got a whole session coming up around partnership with local school districts, and then, of course, your local hospital network. Go to the next.
All right, so we'll go back to the case for a minute. So Addie has continued to struggle at home, and let's say that she has several crisis screens. We will, various designated agencies have various versions of crisis, but all have it. And so let's say in Chittenden County, for example, that's first call, and they've screened her several times, maybe once at school, once at home, once in the community sort of thing. And then ultimately she ends up with an emergency department visit related to more severe like behavioral dysregulation, and then starting to do some self-harming. So she had been set up with some outpatient supports, and she's continuing with those. But at this point, it's felt that, she's reached the level where she needs a more intensive service. And so this leads to her first referral to the Jarrett House program. Jarrett House, and I'll get into this a little bit more, is a short-term crisis stabilization for younger kids, so like 12 and younger, essentially. That is at this point a Monday to Friday program, a 5-day program. In the past, it's been longer, like more like 7 to 10 days, and through the weekends. But there, as with all our programs statewide, there's been lots of challenges with staffing and various things since, especially since COVID, and so at this point, it's a finite period of time for our hospital diversion and crisis stabilization programs for kids. So she goes to Jarrett House on a Monday morning and does the 5-day stay. They do a lot of family work, connect with her outpatient team. The parents, really in school are really struggling with how to support her. And so it's also really not uncommon for kids to have more than one Jarrett House stay. And, we will tell that to families, that's not a failure. That's not a problem. It's sometimes you're just building on what you started the first time. And so she has several Jarrett House stays, over the age 11, 12 age range. And let's go from there and talk a little bit about crisis.
Back to me. So I talked about this a little bit, but this is a way to kind of, visuals are a nice way to be simplified, but they're also simplifying something that's complex. So this is trying to show there's a continuum of crisis care supports. And so if someone is in crisis, the first thing that we hope folks do is to use the 988 lifeline. They could text it, they could use chat, or they can call. And about 95% of those calls actually end up being resolved over the phone. The majority of those calls are answered by folks right here in Vermont. 2 of our designated agencies actually run the lifeline. If they're on a call and can't answer the next call that comes in within a certain time frame, then it gets bumped to New Hampshire. There's a partnership with an entity in New Hampshire who will answer that. And if for some reason New Hampshire can't answer it, then it gets picked up by a national lifeline center. So it will always be answered, but I just did want to note that it is typically answered by folks who are here in Vermont. And even if it's not, the folks in those other centers, they all have access to information about what are the resources that are available here in Vermont. If for those whose needs can't be resolved on the phone, they will be offered a mobile crisis response by that enhanced mobile crisis team I talked about. So a 2-person team who can go out into the community. There are teams who have been going into schools, going to children's homes. They are serving youth. This continuum of care that I'm describing is actually, again, across the lifespan. So for children, youth, families, and adults, and is for people who are in a mental health crisis or a substance use crisis. So if the mobile crisis response is also not able to resolve it, there can be consideration about would that person be best supported in an alternative to ED, so going to an urgent care for some hours of stabilization, or do they need more of a 24/7 type of care setting like a crisis bed? And then for those who have been assessed as having needs that really would necessitate more an inpatient stay, then they would be working with the designated agency around a referral to an inpatient program. But again, we want to try to ensure that we're kind of getting people connected to the right level depending on what their need is. And then at any point, the emergency first responders can help tap into those different parts of our crisis system of care. Let's go to the next one.
So I will talk a little bit about So, I mentioned Jared House about these inpatient levels of care where kiddos would stay outside of the home setting. Jared House I mentioned, and these are all active links. So when you have these slides, you should be able to go, and find more information. But Jared House is run by the Howard Center, but is for kids statewide. It is ages 12 and under, considered a crisis stabilization program. They're running, I believe, a 5-day program now. Like I said, sometimes kids do go home and even come back to do another 5 days. But that is just really on a case-by-case basis. Sometimes Jared House, kiddos waiting for Jared House will wait at home and sort of, be in the community until a spot opens up. But it's also not uncommon for a kiddo, for us, for example, to see someone in the emergency room and decide, we don't think they're quite safe enough to go home. They're going to stay here until that spot opens up on Monday and go directly there. Similar is true for NFI hospital diversion programs. I'm sorry. There are 2 of those, which Laurel mentioned earlier. They are based, one is here up north in South Burlington, and the other is down in Brattleboro, Vermont, but not affiliated with Brattleboro Retreat. That is, similar programming. Previously was a 7 to 10-day program, but is running for similar reasons, a shorter program at this point. It's varied between 5 and 6 days, I believe. Sometimes it's Monday to Friday, sometimes Monday to Saturday. It's essentially one step down from inpatient level of care. They have nursing support, they have a psychiatric oversight, but not regular nursing support. So that's, there's a more of a medical model with inpatient psychiatry than with the community-based support like NFI hospital diversion. It's residential counselors. They do a lot of therapeutic work, a lot of family work. They bring the whole team together, including outpatient therapists, supports, school, that sort of thing. So it's a great option that honestly not all states have, and so we are really lucky to have it, and it meets a very important need in our community when kids don't really need to go to that highest level of care. For inpatient level of care, inpatient psychiatric treatment, our only in-state option is the Brattleboro Retreat. They have 3 units, 2 adolescent units and 1 child unit at this point in time. I'll talk a little bit more about sort of when kids have no option but to go to the Brattleboro Retreat, and that's when they're sort of on an involuntary status. But if for voluntary youth, we do have some out-of-state options that we rely on pretty often. CVPH, or Champlain Valley Physicians Hospital, has a child unit, which, more often has adolescents, but they can take children as well. It really just, as long as they can staff it and sort of create a separate educational and programming track, they will take younger kids as well. Champlain Valley is actually a UVM Health Network hospital. So it's UVM child psychiatrists. It's like I work there on the weekends sometimes. They're affiliated with our academics. Our child psychiatry fellows rotate over there. So it's pretty well embedded. But there are limitations on who can go there because of the complications crossing state lines. So you have to be essentially quite voluntary and really invested in treatment. Family has to be able to travel over there, usually on the ferry. So there are challenges to it. New York operates under totally different legal statutes, which is also a little bit challenging in terms of psychiatric placements for kids. So it's a great resource, just not for every single situation. Four Winds, there's actually more than one Four Winds. We're most often referring to the one in Saratoga, New York, another adolescent inpatient unit, but they do have one down in Katona, New York, which is Westchester County. So Four Winds requires private insurance. So CVPH will take Vermont Medicaid. Four Winds is commercial insurance only. They will not take Vermont Medicaid. So when we're making referrals, that is one of the barriers we have to address.
I do want to pipe in and say there are other inpatient settings
Yes.
for youth around the region. So if there's a youth who has particular needs that actually can't necessarily be met at these, or they just can't get in for whatever reason, we have worked with our Medicaid partners over at Department for Vermont Health Access to identify what are some other settings that youth can go to. And so they've gone to Maine or a place in New Hampshire. So just wanted to name that these are not the only ones, but they're the most commonly used and more regional for families.
Exactly. And this might not apply as much to the sort of medical home partnership, but we often in emergency rooms, for example, are seeing kids from across state lines, like New York kids. If there's an ingestion or something like that, they end up at the UVM medical center or in the UVM emergency department with New York Medicaid, with New York insurance. And so that in those situations, often we are referring to more places because they have more options within New York because they're New York kids. And so this is really just the list that is most commonly accessed by Vermont kiddos, but sometimes we're referring to, programs in St. Lawrence or that sort of thing, really just on the suggestion of the home team, that knows the New York State's resources better. All right. I'll talk briefly about the alternatives to EDs that we mentioned. This is, so 4 of our designated agencies have alternative to ED programs at this point. UCS, United Counseling Services, has the PUC program, Psychiatric Urgent Care for Kids. That's an intensive day treatment program for youth that has clinical assessment, skill building. It's a Monday to Friday option. Some kids go multiple days in a row. Sometimes it's just sort of like a one-off, crisis intervention, and it serves youth of all ages. HCRS has a youth stabilization program that is located in Brattleboro, Vermont, provides intensive support to help youth stay at home rather than having to go to a placement of any kind, and has a range of therapeutic services. Again, another Monday to Friday program. Lamoille County Mental Health has the Emergent Psychiatric Intervention for Children program, or EPIC, and that's similar to PUC and has that intensive day treatment and support for kids 6 to 18, a Monday to Friday program. And then Northeast Kingdom has the Front Porch program, which is 24/7, 365 for all ages, and that provides assessment and case management services without having to go to an emergency department. Did you want to say anything else about those, Laurel, or does that feel like enough?
That's good. Let's
Okay.
keep going.
Great. So let's go back to the case for a minute here. So around age 13, Addie starts experiencing just escalating struggles as she enters adolescence in the community and at school, despite some really solid, significant wraparound supports and family involvement. Police were involved once related to aggression at home. She briefly ran away from home, but ultimately was safe. Her self-harm is really a sort of persisted and escalated, and she eventually has a suicide attempt via medication ingestion. She has 2 admissions to the Brattleboro retreat for self-harm or suicidal behavior. So at this point, I just want to type in the chat, what are people thinking? Like if she is part of your office and you're not really sure what to do, how else to support this family, what is coming to mind? Anyone have thoughts that they would want to put in the chat? Or what questions do you want to know or don't want answered? Jess is going to tell you exactly what to do next. So if you guys don't have ideas. Okay. In the interest of time.
All right.
We will keep moving.
Totally. So
Jess, take it away.
What often happens in this type of situation is the question of having an Act 264 gets raised. So I'm going to do a super brief, because could be its own training for multiple hours, about what is an Act 264 and why would you have it. So it is a legislative act that was created in the 80s. And it is an act that entitles families to coordination of services. So if we think about the case example that we have a young person who's struggling, we have a team of providers and some people, and they're not sure what to do. Great time to have an Act 264 and have this coordination of services. So what we just have on the slide is a little bit about what the act entails. It has a definition of severe emotional disturbance. It creates the actual plan that you go through, which creates the agenda for your meeting. It creates the LIT team that is, there are LITs across the whole state in each district, and then the SIT team, the next consultative body after LIT. And then it, again, has some advisory components to it. And it really emphasized the idea that we are coming together to holistically look at a young person and their needs and coordinate services. And that is often when you often, as in have to get someone from the designated agency involved. So as part of the Act 264 process, it is required that you have a mental health rep, and mental health reps are those people who are either from a designated agency or from NFI Vermont. You can go to the next slide. Awesome. So in the case of specifically thinking about Addie, when we are thinking about wanting to access higher levels of care, like, hey, we might be thinking about a residential level of care for a young person. This little schematic really highlights the process. I think it's a nice little visual. We at the local level will have an Act 264 meeting. We create a coordinated services plan. And if the team is looking at requesting residential via accessing Medicaid dollars to do that, what happens is that we create a CRC or case review committee packet that then gets sent up to the appropriate AHS department. And so that could be DMH. In some cases, that could be Dale, our DS folks, education, etc., or through substance use. So once that AHS department is determined to be like the lead for that the residential request, it moves on to the case review committee. They are the committee that reviews that packet, makes sure that they are looking at all the clinical factors, eligibility, et cetera, and make the recommendation on whether they're going to approve that request. And then that process continues to move along, always including and keeping the local team involved. So the local team remains the kind of drivers of the plan. They're the ones that end up making any referrals and staying involved as appropriate when a kid goes to residential. So I just want to then say this slide really highlights if we are looking at a residential or that highest level of care. But I want to always give a plug that an Act 264 can happen even if you're not talking about residential. So an Act 264 is a great process just to bring everyone together, to problem solve, to brainstorm, to think about what next for a kid at any level of care. It really can just be about using the process to think about a young person. And then I always want to give a plug that anyone can run an Act 264 meeting. It is not just people who are from a designated agency or from education or DCF. Anyone can run a meeting. It is about making sure that you have the appropriate players. And so always want to give a plug that there are a lot of ways to access trainings for Act 264. And we're going to talk about that a little later too.
Laurel.
Honestly, I think this is a little redundant with what we've shared with our levels of care. I will note there's another acronym in here where we are in process of standing up an in-state psychiatric residential treatment program known as a PRTF, which is just below inpatient level of care, but more of a residential type. And then we do have residential treatment programs, group homes, which are much more embedded in community, where youth who are in a group home for residential treatment also attend a local school, whether it's public school or a therapeutic school. So they're more immersed within the community. And then we can provide some intensive wraps within the home. So I think that's how we think. Yep.
And I would can I just add, I think, so we are talking pretty exclusively about Medicaid driven programs and Medicaid funded programs, but as the needs of our communities have changed, we are seeing many more families that have a primary commercial insurance, Blue Cross Blue Shield, Cigna, Aetna, et cetera. And that process to access levels of care at any level and specifically at a residential level of care is very different. And so that's when I would encourage you all to be connecting back with whoever your contact at your designated agency is. So for me at Howard Center, I have a little tip sheet that I share with providers on how to really problem solve and work through the process of using commercial insurance for different levels of care.
Yeah, and our care management team is actually finalizing a document similar to be able to make available to families and providers working with families who have commercial insurance only around how do you work with your commercial carrier to identify that this is medically necessary and then identify programs and go through that process. So hopefully that will be finalized soon and up on our website and then spread through the designated agency system. Let's keep going. This is just data you can look at later, kind of tracking kids who go to residential through funding from Department of Mental Health, disability, developmental disability services through Dale, and then kids who are in state's custody under Department for Children and Families. But you can review that later if you're interested.
All right. And then for the highest level of care, that's hospital level inpatient psychiatric treatment. 6 hospitals in Vermont at this point have inpatient psychiatric units, but only one of them, as we talked about, serves children and adolescents, and that's a Brattleboro Retreat. And so DMH designates inpatient hospitals to provide services to individuals who are in the care and custody of DMH. And if you're in the care and custody of DMH, that essentially means you're hospitalized on an involuntary basis. Involuntary hospitalization, as it says here, is always a last resort. We are always trying to, serve people in the least restrictive levels of care possible, and, embrace patient autonomy wherever we can. But when there is at sort of an imminent risk to self or others, and someone is unwilling to accept psychiatric treatment, and it's clear that it is related to a need for treatment, is a person in need of treatment, then you may have heard the EE process, or emergency examination process, can be pursued. It's a 3-stage process, that is a 3-stage essentially application that involves usually, one licensed, one designated person who can play various roles, like a crisis clinician, certain type of crisis clinician, or a physician. Then it goes to another level, another sort of application, and then a psychiatrist has to sign off on it as well. So it's it's certainly not taken lightly. When a child is placed on that status, their only option becomes Brattleboro Retreat, because it's the only designated hospital. Once a kid is on, or anyone is on an involuntary status, you can't cross state lines, and so it limits your options. And for us, that means only Brattleboro for kids. It's also just worth noting that any person over 14 can actually consent to their own treatment. So sometimes, if a family, is not accepting of a kid's mental health needs, or, it's a 16-year-old who's like, I really want inpatient treatment, they can consent themselves into inpatient treatment on a voluntary basis. Under 14 does require a parent or guardian signing off. And when someone no longer meets hospital level of care, when it's moved towards time for discharge, DMH for those with Medicaid, for those who are interacting sort of with state Medicaid, or who were on involuntary status, DMH partners with hospital and community partners to develop discharge plans and figure out kind of what the next step is. Sometimes it's step back down to the community. Sometimes it could be a step down to like a hospital diversion type program. Sometimes it means residential, is next for them. It really is very much on a case by case basis.
I just want to add in here. Oh, there's echo. I think if folks can mute, that might help. Great. We really do want to emphasize and hope that you in primary care settings are also getting notified when one of your patients is going to inpatient, or if they're discharging back out into the community, and what their medications might have been from an inpatient type setting. So we know that things don't always go smoothly. If there are themes of concerns or questions about how come it happens this way, we are glad to engage with you and talk through any of those. So our emails are on the front cover of the slide deck. We can pop them in the chat again also, but I wanted to make note of that, because you're a key part of this transition back into community, or helping maintain kids in their community. So
there has been a concerted effort to communicate with primary care offices as well. I mean, I can speak for UVM anyway. Like we use it as a quality measure in the emergency department for every kid we see, that we are calling the PCP office and making sure they know that this kid came to the emergency room. This is what's going on. They're going to the next step, or going home, or whatever it might be. And I do know that Brattleboro Retreat has been working on that as well. They recently did a quality improvement project, tracking how often primary care was involved in sort of the dispo planning and whatnot. So it's certainly front of mind, but the more squeakier wheel you can be, the better, truly, because it's so important as kids step down. And that's been a longstanding challenge of our system, especially having just the one hospital in a certain part of the state. Trying to connect kids back to services 2.5 hours away is tricky. And so designated agencies have really stepped up in that way too, to try and help with that process. I know Howard has done some of that work, trying to transition kids back into the community when a discharge is pending, so just can't stress enough how important it is for the medical home to be involved. Question, yes.
Yes, hi. Lori Burnett at Monarch Maples Pediatrics. What is the state's view on, or Department of Mental Health view on, when a patient of yours that you've been working with for a little while in the office is seen by crisis, whether it's Chittenden County, Franklin County. What is the best practice or standard? When I used to work in an agency, they would notify you right away that your kiddo was seen, screened. But is there anything about that? Because that's a problem.
I think it's a great question. Similarly, we are hoping that that communication can happen. I encourage you to connect with your local designated agency and even ask to talk with someone from the emergency services team to ask, how can we have that feedback loop or that loop back so that you're aware that there was a crisis outreach with this particular youth who's one of your patients. One thing that we've emphasized with our designated and specialized service agencies is we want them all to know who is the primary care provider for the youth that they are serving so that they have that information within their electronic health record. I think there are kind of longer term goals around how can they connect in with the health information exchange, and is there a way to have that kind of notification happen, but I don't think we're quite there yet. Jess, anything you would add from your lens?
Yeah, I think, I mean, again, I can only speak from Howard Center in the first call perspective, but within our team, we have designated supervisors and staff that are point people for different like liaison relationships. So like we have a supervisor who's connected and does like some of that relationship building with UVM, or we have someone that's connected with like the community health team. So find out who those people are, like Laurel said, give a call and find out who your point people are so that you can make sure that that relationship is happening.
All right. We're nearing the end here. Laurel, briefly, you want to say anything about capacity?
Yeah, we have a bed board that DMH manages that all of our emergency services teams from around the state have access to. And so and then all of our crisis beds and inpatient programs feed into it every day to indicate how many beds do they have that are occupied, how many are closed for various reasons, and how many are open or anticipated to be open. So this is a point in time snapshot from 2 days ago of what it looked like. And Haley noted, especially with our child and youth crisis beds, because of lack of staffing, they're only running, I didn't have this one updated. I had a slide that included a column of the hours or days that they were working. Maybe I'll get that updated to Elisa to replace. So just wanted to highlight, this is what it looks like. These are the number of beds in these different programs, but it's always fluctuating. So there's usually some open beds somewhere, and then anticipated knowing like when a discharge is likely to happen, that there's another opening coming. Next slide.
Thanks. All right, we're going to do one more quick poll. This one should be even faster for those who can participate. Thank you very much. And if you don't, let's see. Is this going to let me do it? There we go. Feel free to write in the chat if you aren't able to access the poll.
And there are 2 questions on this one too. So
Yep,
hit the little arrow on the bottom.
Just click through. Yeah. Just give it 30 seconds or so. So the first question, do you feel confident determining level of care your patient needs? And then second, when you refer, how often do you hear back? Kind of talking about that, collaboration and, open communication. How often do you hear back about whether they connected? All right, so I'm going to close the poll. Looks like we've got about 20 or so responded. Okay, so about 53%, you should be able to see this in the chat, can see that I can see that 53% usually feel confident determining level of care. So usually and sometimes, okay, so not that many people feeling rarely, but hopefully for those who do feel like you're not really sure, this helps a little bit. But I also really would encourage you to reach out, to whether it's your DA or, it's probably start with the DA and they can always escalate as needed. But these slides are a great place to start too, in terms of like, clicking through the links and figuring out, okay, that makes a little more sense. Now I might know where to go with this and how to advise people or, a family who's wondering what's next. Let's see. In the next question, when you're far, how often do you hear back? so let's see, 58% said sometimes and 11%. So we've got about 70% are usually, or at least sometimes hearing back. We should be able to do better on that, I think. So that's definitely, and not necessarily on you. That's kind of on all of us, as we, I think it's just best practice to reflect back to whoever made the referral, that the kiddo connected or the kiddo or family connected. And I would really encourage you again to be the squeaky wheel and reach out, because it's so important, as things go, we're all so busy and it really does get lost. And so if it's been a couple weeks and you're like, what happened there? Yeah, I would absolutely say just give them a call. And that's a good segue into Jess's last slide here.
Well, we have two, because
Oh, two. Yep.
I actually do want to
Yeah.
highlight another way that you can access support for figuring out level of care is the Vermont Consultation Psychiatry Access Program, which is our last slide we'll get to in a second.
Yep.
We've said this a few times, but I really, when I was asked to join these ladies with this presentation, was like, how do we support medical home and DA relationship? I was like, know your people. So like in your region, find out who your people are. So who does intake for your designated agency, or how do you access intake for your designated agency? Who is the maybe intensive services coordinator? So my role, there are people that do my role coordinating intensive services in all of the other DAs. And so find out who that person is, because they are a great resource and sounding board to be like, where do I go? I have questions, or people are starting to raise questions about level of care. So find out who that person is. There are many people on this call now who call me. So find out who that person is. If you need help with it, I know some of those people. But that, like, again, know the players. Make sure that you reach out and know your crisis supports. Again, we have all the different levels, including some of the alternatives to emergency departments and 988. Find out if your designated agency, who your LIT or local interagency team coordinator is, or your CIS or Children's Integrated Services coordinator. So like, again, figuring out who point people are to help you then navigate and figure out the next steps for a kid or youth. Attend an Act 264 training on the IFS website there. I think there's a pre-recorded one that Rutland Mental Health did. There's a lot of resources and training guides out there. Or connect to your DA. I know I run Act 264 trainings for Chittenden County here with Howard Center and NFI, and I welcome anyone to join them. So connect with your DA and say, hey, can I join a meeting or a training? And then if you are involved, and once you're involved and you've got relationship with your designated agency supporting youth, stay involved. So stay in touch with that person, ask to join team meetings. And that's really at any level of care. So if we have a kid going off to residential, even if it's out of state, stay connected, because those kids will be coming back, and we want to make sure that we're building those partnerships for good discharge planning. That's it.
Oops,
Thanks,
sorry.
Jess. Oh, okay. I'm like,
Yep.
what happened to that slide?
Yep.
So Ellen popped this into our chat earlier, but wanted to make sure that everyone's aware of the Vermont Consultation and Psychiatry Access Program. This is funded through 2 federal awards, one through our department, one through Lisa's team. And it is for people who are perinatal population or children and youth up to age 21. And they can provide consultation around mental health questions, diagnosis, treatment, et cetera. And then there are also, so that you can access a psychiatrist for some consultation around those, including medication management. And there are also social workers who can help either think about treatment planning or connect to necessary referrals in the community. These programs also support some training opportunities, and the team of Ellen and Greta Spotswood, Dr. Spotswood, are going to be talking with you all late in March. So you'll hear more about it then and can get into some more detailed conversation about it. But glad to answer questions about that or anything else we've covered today, because that's it. We were hoping to keep it to an hour. We're a little bit over, but if you're able to stay on and you want to ask other questions, we're glad to stick around and talk with those.
And while before you pop off, there is a final